Good evening to all of you. As usual, we'll start with a short case first. Is my screen visible? Screen is visible now? Joy, is it visible?
Yes, sir, visible.
Okay. So this is a story of a twins aged 13 years. Both of them noticed difficulty in getting up from squatting position and buckling of knee for the last 5 years. History of dysarthria for the last 3 years. This is the twins. I will show the progressive difficulty in getting up from squatting position for the normal. No ptosis, no ocular movements normal, ocular movements and the cat is speaking. No facial paralysis. Muscle weakness of both upper limbs, but predominant affection was in the wrist extensions and finger extensions. The other hand. It's a possible slowly. It's also got difficulty in getting up from squatting position. Repeatedly asking him to get up. You cannot get up after 2 o'clock. But another time. In that case, not time. Ultimately. It also gets fatigable. So fatigability more in the extensions of the fingers. So what is the diagnosis? Twins with the same problem, cranial musculature normal, weakness of upper and lower limb, predominantly distal in the upper limb, finger extensions, and the muscle weakness is fatigable.
Myasthenia, congenital myasthenia.
Okay, which congenital myasthenia? But cranial nerves are all normal. Ocular movements normal.
1B, sir. 1B.
Since for the last 3 years.
1B, sir.
1B means what? I don't know. This one. Can you tell me sensitive deficiency or something like that?
Slow channel syndrome, sir.
Slow channel syndrome. Okay. Anyway, why do you say slow channel? Why not any other ocular myasthenia? There can be lingual myasthenia of dog 7.
This is a predominant extensor weakness, hand extensor weakness. That's a point. Then family history, I'm not very sure whether it runs like this. It's autosomal dominant or something.
Okay, these both the family members, they are twins.
Okay.
Okay. So, okay, what test you need now? I'll show the test. This ulnar CMAP. This is the abnormality on ulnar CMAP. What is this abnormality?
Double CMAP.
Yeah, this is a repetitive CMAP. Where do you find double CMAP?
Slow channel.
Slow channels. There are 3 conditions. One is slow channel syndrome. The other condition is acetylcholinesterase deficiency. And third is OP poisoning. Organophosphorus poisoning also you can get this kind of a double CMAP. So you may remember this patient. This is a protein fluoxetine and the patient improved remarkably well. This patient, this is one condition where you should not give neostigmine, just like acetylcholinesterase deficiency. This is the double CMAP. For repetitive CMAP. Pardon?
fluoxetine. So which are the condition where they would respond to ephedrine and certain condition?
Like, this also will condition also respond to ephedrine and sympathomimetics and fluoxetine. But ephedrine is not available. You can't get it. Even at that time, it was very difficult to procure, not in the market. That's why we started on fluoxetine.
How do fluoxetine work in this condition?
I know, no idea.
Some SSRI, something like that.
I don't know why it is. The sympathomimetics also works. Probably, I don't know how it works. Okay, just remind you that if you get distal muscle weakness in congenital myasthenia, especially finger extensors, you have to think of slow channel syndrome. They can also have scapular wasting, scapular muscle can be involved, and muscle wasting can also occur in slow channel syndrome. So now with that, I'll go to the proper two cases.
So these people seems to be quite muscular. How's that possible?
Well, I don't know. They're normal. There's not hypertrophy. They're normal. There's no wasting of the muscle just like any other myasthenia. But I don't think they get hypertrophied. Hypertrophy in myotonias.
Okay, sir.
So this first case is a 65-year-old man with known case of hypertension and diabetes. He presented with acute onset of vertigo and vomiting and imbalance while walking for 1 day prior to presentation. No other complaints. There's no tinnitus, deafness, headache, or any other cranial symptoms. This is the video of the patient. Look carefully, you're looking to the left side, it's a fast beating nystagmus to the left. So you can make it out clearly now. When primary personal suite is beating to the left. Look to the right side, there is no nystagmus. Looking at ocular movements are all normal. This is a thrust test. The left side is happening. Turning to the right side. This the threat is positive and lift detected to the right side. Left side. There is no fingernails in coordination. Come to the gate. Stand lower limb does no incoordination, but on standing, you have got a Pusha syndrome. It tends to fall towards the right side. Especially when he closes eye, he tends to fall more towards the right. When walking, is again tendency to fall towards right. Okay. What is your diagnosis in this patient? Anything other investigation? I mean, there's no other finding. The blood is normal, sensory system normal, hearing normal.
Right vestibular neuritis.
Right lateral medullary
syndrome. Okay, lateral medullary syndrome. If it is lateral medullary syndrome, where do you think the infarct would have been, on the right side or that side?
Right side, sir.
Right side. Okay, but head thrust is positive here on the right side.
Left vestibular problem also.
No, if it is vestibular, it is right vestibular, peripheral vestibular. Because head thrust is positive on tilting there to the right side. I'll show you once again that part.
Sir, is it possible to have a higher relation because he is lateral pulsion to the right side?
Correct. Lateral pulsion to the right side. So lateral pulsion can occur with if it is in the medulla, it is on the right side. If it is in the pons and embouchure, it is on the left side.
Yes, sir. I think it is high up, sir, because it is just opposite to that.
Okay. But you
Would
look
we
at
get
it.
a nystagmus, sir? Would we get a
Also there is.
no, sir. Would we get a nystagmus?
Yeah, he has got nystagmus. I'll tell you.
No, sir. If the lesion is higher up, do we get a
Yeah,
nystagmus?
you can get. The nystagmus can occur in various sites.
Okay, sir.
Maybe even on the midbrain also you can get nystagmus. It's a vestibular condition. Look at the head rest. Left side is normal. On right side, let's see the hip thrust is positive on tilting to the right side. It indicates the lesion is on the right peripheral labyrinthine lesion or root entry is shown in the vestibular nucleus on the right. So it could be, as you said, could be right medullary lesion is possible, but unlikely to be a left, as Umar said, it's unlikely to be on the left side because you can't explain the head thrust to the right side. Positive head thrust to the right side. Okay, so all of you think, so what is the final conclusion?
Whether there is a lateral pulsion, sir?
There's a patient tends to fall towards the right side.
With the eyes actually, or a lateral pulsion in the eyes would favor a medullary lesion.
Okay, you want to look into that, correct? Okay, with this finding, what do you think?
Pontine lesion on the left side.
Right.
Would we get a Hinds positive with the pontine lesion?
You can have, except one thing, skew deviation may not be there, but you can have positive head thrust test, you can have unilateral side beating nystagmus, something like a peripheral nystagmus, all can occur when the root zone is affected. Even lateral lesion also can produce beating nystagmus only on one side, so called pseudo neuritis. Okay, so as you said, you want one more test. So any other bedside you need, look for CUD, which as somebody has correctly suggested. This is a very poor video. It was not taken by my patient's relative only, so you could not focus it correctly. Anyway, skew deviation was not there. So what do you think? Peripheral lesion or a central lesion?
Right vestibular peripheral.
Central lesion.
Central lesion, sir.
Central. But skew deviation is negative. It may not be there in always in a brainstem lesion. Only sometimes it may be. If it is present, it is okay.
Sir, where do you use this uncover test for skew? Can still visible?
No, sometimes mild disconjugation, you will not pick up just looking at the patient's eyes. So what you do is that when you cover, uncover, move one cover to the other side, you can see the eye moving up and down. Because one eye is up, one eye is fixing on your target. When you move the cover, the other eye has to come down and fix it onto that. So you can look at the movement up and down when you move the cover from one eye to another. So always do this test at the bedside to find out a mild skew deviation. Otherwise, you may miss it. You may think that it may be normal. It's unless a gross skew, you can make out by just looking at the eyes. Otherwise, better to do this cover uncover test. Okay, let us show another case. This 56-year-old man presented with acute onset of vertigo and imbalance for 2 days, just like the previous patient. This is the patient. He has also got the same beating nystagmus to the right. So here it is present on primary position as well as on looking to the left side, it is beating to the right side. See, it's beating to the right. Even on looking to the left side, it's beating to the right. Beating to the right side. There's some mild suspicion of rotary compound as well. So he has also got imbalance while walking. So what will be your diagnosis in this case?
There's a skew, so it will be a central lesion.
Skew deviation is there on the, okay, maybe some skew deviation, correct?
Right, hypertropia is there. Sir.
Right.
And he has a ptosis on the left side.
Okay.
And there's a skew and as well as a predominantly right beating nystagmus.
So the problem with the ptosis
also.
He had no Horner syndrome. The problem with the ptosis is that when the patient's got a skew deviation, one eye down, that eyelid will be lower down. So that part will be doubtful unless you take with only if the pupil is also not affected, then you take with a pinch of salt only ptosis is there. But you have got a point that can be a very possibility.
Here there's a reverse ptosis also on the left side, sir.
Not very. That's very difficult to convince here because already the eye is low. No, the lower eyelid is going to cover up. So even if it's reverse ptosis, that will be masked.
He's got a head tilt, which would say it's a.
Yeah, maybe in the brainstem. Agreed. But what other tests will you do in this patient? These two patients. To find out whether
you can cover uncover test. Cover
yeah,
uncover test.
I don't know. I forgot the doctor's name. And she correctly said it is the lateral position to look for. So he's got a right beat nystagmus. See, the nystagmus is peripheral. Remember this point. This patient nystagmus is a typical peripheral nystagmus. It is beating to one side or looking to the right, primary position, as well as looking to the left side. There is a typical and side beating nystagmus of direction fixed nystagmus. The other patient also got a direction fixed nystagmus beating towards the left side. So this patient also had thrust was not very definite. Now, what is the diagnosis? The test is, let's do the test, the first patients.
So right vestibular.
And this is the first patient. Okay. I asked him to close the eyes and open the eye to find out a lateral pulsion. Lateral pulsion. There is no lateral pulsion in this patient.
The right vestibular in this patient.
Correct. This patient has got a right labyrinthine in. There is no lateral pulsion. Let us do the test on the other patient, second patient, which you all thought is a lateral release. See, it's got lateral pulsion to the left side. Close the eye and open. It's coming back. So when you have got a problem in differentiating whether it is an acute labyrinthine or a lesion or a medullary lesion or a brainstem lesion, this test is going to be very helpful, especially lateral syndrome. You look for the lateral pulsion, ask the patient to close eye for some time and open it. The first patient had got almost similar nystagmus, side beating. It also got a nystagmus typical of peripheral nystagmus. And this peripheral type of nystagmus seen in lateral syndrome is called the pseudo vestibular neuritis. This, I think, sometime back I had shown a similar case with the pseudo vestibular neuritis. So never forget to do this, looking for lateral pulsion, which is not mentioned in the hints or hints plus. So you can call it as a hints plus plus. Include lateral pulsion also in the examination. In the first case, from the history, finding itself, you should diagnose peripheral because if all three things should be negative, suggestive of peripheral to call it peripheral. That is, hue should be absent, head thrust be positive, and side beat, direction fixed nystagmus. All three things should be there. If any one of them is favoring central, think of a central lesion. But all these tests have got certain caveats because skew may not be present even in all brainstem lesions. Even medullary lesion can produce a side beating or a direction fixed nystagmus. And head thrust can be falsely positive in a root entry zone in the vestibular nuclei. So these are not foolproof, but all the things are favoring peripheral, suspect peripheral lesion by hints. That is why we are now embarking on hints plus. In addition to these things, the patient would associate deafness. It is a point favoring a central lesion, not peripheral lesion. Second is the ataxia. Significant ataxia when the patient requires the help of a person to walk about, but the patient cannot sit steady and tend to fall to one side. That favors a central lesion. And in the first patient, you thought there's got some lateral pulsion, no? So that can occur in peripheral, acute peripheral labyrinthine lesion. That is the basis of a Koda's test and all. So they tend to deviate to one side, especially when they close the eyes. the same side of lesion. That is why when he stands, he falls towards the side of the labyrinthine lesion. But this disappears after a few days. So any questions in that case?
If lateral pulsion of the body can take place, why there is no lateral pulsion of the eyes?
That I don't know, but that is because of the vestibular spinal system is affected. The connection to the vestibular nuclei to the ocular muscle, that's not affected. That is the reason. And most of the time, acute labyrinthine lesion, they don't fall. Only when they close, they fall to the same side. But within few days, that gets compensated. The opposite thing, the labyrinth will take over and can maintain the balance through the vestibular spinal system.
But the first patient was tending to fall while walking, no?
Yeah, he also while walking tending to fall to one side.
But was he keeping his eyes closed that time?
No, he was not keeping his eyes closed. Eyes closed, it become more. That's when what you usually see is with eyes closed, then to fall. But even with eyes open, they can fall to one side, the acute setting. That's why the confusion came in this patient, these two patients. He's falling to one. Initially, we may think that it is a labyrinthine problem. A central problem. So you want to see the MRI of this patient?
Sir, one second. Sir, in this case, how to differentiate between ICA infarct in this case? Because ICA can involve the labyrinth as well. So
exactly. What you asked is perfectly right. It is often the ICA infarct which causes the greatest confusion from peripheral labyrinthine nystagmus. ICA infarct can produce positive head thrust because ICA supplies the vestibular nuclei where the vestibular nerve enters. So the same thing will occur with the ICA infarct. Secondly, ICA infarct can produce infarction of the peripheral labyrinth because the labyrinthine artery arises from the ICA. So it can produce a peripheral, exactly like a peripheral nystagmus. So these two things are the one favoring ICA. I mean, not favoring, these two findings will have, are finding it difficult differentiation peripheral because they are common for both. So positive head thrust test and unilateral nystagmus can occur with the peripheral lesion as well as ICA lesion. But in ICA lesion, what you get that if the peripheral labyrinthine nystagmus occurs, it also produces a deafness also. Because that artery that supplies peripheral labyrinth is going to supply the cochlea also. So invariably, that ICA infarct producing a peripheral labyrinthine nystagmus will have associated sensory neural deafness. That is why in HINS plus, you are taken, if you got a deafness, think of a central lesion. Because why it is, then you may ask, why not acute labyrinthitis produce deafness? Yes, but that is a very, very rare entity. So you must have seen so many cases of acute vestibular neuritis. Every 1 month you may see an OPD patient acute vertigo syndrome, peripheral vertigo syndrome. But none of them complain of tinnitus and deafness along with vertigo. Because in acute vestibular neuritis, it is the vestibular nerve which gets affected, not the entire labyrinth. Very rarely you can get labyrinthine involvement produce deafness like for example syphilis or purulent labyrinthitis, something like that they can have. But the usual garden variety of a viral vestibular neuritis, there is no deafness. That is why when you get deafness, along with that, think of a central lesion. That is more likely the chance.
Can an ICA lesion produce both central as well as peripheral involvement?
Yeah, it can produce both the central and peripheral because the labyrinthine artery is arising from the ICA. So it can produce a peripheral involvement. Plus, they can have a central lesion because it is obviously supplying the brain.
So which symptoms or which signs would predominate, central or the peripheral?
Where in ICA. They can produce both, no? Because peripheral all will be there. If the labyrinthine artery is affected, you can have also central also. They can have cerebral sign. They can have a facial involvement. Other things can be there. Facial sensory loss, everything can be there.
Would ICA lesion produce a vestibular lesion centrally?
Yeah, it can produce, but the vestibular nucleus is affected.
So which signs will predominate? The central vestibular signs?
That depends upon which part of the brain, which part of the labyrinth, whether the labyrinth got affected, severe affection, the other got severe affection. Sometimes the labyrinthine artery may directly arise on the basilar. Need not be from the ICA.
Sir, in this case, what would suppose the ICA infarct as well as this peripheral labyrinthitis?
Yeah.
What would be the characteristic of the nystagmus? How can we differentiate?
If it is a typical vestibular nuclear involvement, let us see, not the peripheral, the pseudo vestibular neuritis, you forget about it. Vestibular nucleus, central vestibular nucleus involvement, you get a direction changing nystagmus. Changing nystagmus means that the nystagmus be to the right when you look to the right side, be to the left when you move to the left side, just like a gaze movement nystagmus. But they will have a primary position nystagmus. And that central vestibular nystagmus will not get worsened by avoiding fixation. Okay, that is one point. The peripheral nystagmus is always beats to one side, one direction. That is to the opposite side of lesion. Suppose my left labyrinth is mauled by infarct or acute neuronitis, I get a nystagmus which beat to the right, and that amplitude will be more when I look to the direction of the first component. So-called Alexander's law. That means that it will be more on looking to the right side. Suppose my left labyrinth is affected, I get a nystagmus beating to the right and be more on looking to the right side. Little more severe affection will be there even in the primary position looking to the right, beating to the right side. Still more severe, even on looking to the left side, it beats to the contralateral side. Opposite to what you get against the wound. Even if you look to the left side, it beats not to the left, to the right. So it's a direction fixed nystagmus. Depending upon the grade of involvement, that is why grade 1, grade 2, grade 3, you get only contralaterally, central plus contralaterally, even plus ipsilaterally. That is a classical peripheral vestibular nystagmus. In the case of central vestibular nystagmus, it is direction changing. It will be on looking to the right side, it beats to the right side. Looking to the left side, it beats to the left side. But there will be a primary position nystagmus also beating to the contralateral side. That is the point. And secondly, the peripheral labyrinthine nystagmus will get worsened by avoiding fixation, by looking at the ophthalmoscope and closing the other eye. On the other hand, the central type will not get worsened by avoiding fixation. That is how we differentiate with the peripheral labyrinthine nystagmus or the central vestibular nuclear lesion producing nystagmus.
But this peripheral also can produce a primary position nystagmus. The first patient had a nystagmus.
Yes. That's a classical. The peripheral also can produce. But the thing is that it is not direction changing. It is the direction changing which differentiate between central vestibular versus peripheral vestibular.
So the Alexander law is applicable for a cerebral lesion also?
No, it's applicable only for peripheral lesions, not for central lesions.
Okay.
Okay, you want to say the first MRI, the first patient? This is the MRI, the first patient who we thought peripheral. With the so-called lateral pulse, we thought no. So they wanted to take the cervical cord also, they took. That's all normal. There is no infarct. I'll show the diffusion. There is no distribution. It's a coronal cut again showing no abnormality, no infarct in the first patient. Now coming to the second, but there is another interesting finding in this patient. There's a fluid between the atlantoaxial joint pressing on the vertebral artery. Yeah, forget about it. This MRI second patient, you can see the left lateral ray. The one with saccadic lateral pulsion to the left side. Okay. So if there's no question, we can go for another case.
So peripheral nystagmus, what is the clinical utility of grading it?
Little utility of?
Grading peripheral nystagmus, grade 1, grade 2.
Utility only thing is it's a severe nystagmus will produce nystagmus in all three directions. That's all. More symptomatic, probably more symptomatic because the severity is more. Any questions?
Sir, migraine can present with the central vertigo pattern, no, sir? So
Yes.
MRI can be normal.
Yeah, perfect. What you said is correct. The migraine can produce phenomenon, nystagmus mimicking peripheral or mimicking central, but more often mimicking central. Can also produce just like a BPP-like phenomenon during migraine attack. So these are all well known described in migraine.
And lateral pulsion, does that occur contralaterally, away from the lesion?
In
like
brain, yeah, it can produce in brainstem lesion. It's away from the. Suppose it is in the last week, 2 weeks back, I showed a brainstem fontaine infarct with the contrapulsion, whether you remember or not. So in fact, at that time, I told about the graviceptive pathway from the otolith organs, which cross to the opposite, ipsilateral vestibular nuclei, cross to the opposite side, ascend in the embellum, and go to the interstitial nucleus hall. That is for maintaining the ocular movements, and then to the thalamus and the cortex for your the perception of verticality in relation to gravity. That is a graviceptive pathway. If that pathway is affected before crossing, that is in the otolith organ or its connection to the vestibular nuclei, as in lateral syndrome, you get an ipsipulsion. Once it has fibers has crossed and ascended up, once it reaches the pons, that means it is after crossing. That means you get the same thing, but it's only to the opposite side. You get a contrapulsion. Because what is damaged is the contralateral labyrinth is dysfunction. So you get a contrapulsion. So anywhere after crossing, be it in the thalamus, be it in the pons, be it in the midbrain, be it in the thalamus, you get only contrapulsion. Okay. So here
Sir,
it is.
Sorry, sir.
Please carry on.
In thalamus also we get patients are having some sort of ipsipulsion to one side. Is it because of this graviceptive pathway? Because they get some sort of.
There is two explanations for that. One is this kind of a thalamus, you can, if not ipsipulsion, contrapulsion. They tend to fall towards the opposite side. And there is another interesting phenomenon called Pusha Syndrome, where you get usually not only in this kind of the explanation is not only confined to the graviceptive pathway. There is another explanation offered for lesions in the thalamus in the parietal lobe, causing pusher phenomena. So they actively push to the opposite side of lesion. Suppose the patient's got a hemiplegia on right side, when they sit up, they push toward that side. That is another phenomenon called Pusha Syndrome. There is also from the explanation given because of the proprioceptive and sympathetic input from the contralateral side is not reaching the parietal lobe for proper maintenance. That's an explanation for that. Here it is different. It is the vestibular input which is going to the thalamus and the parietal. That is affected. So shall I go to the next case?
Yes, sir.
Yeah.
Yes, sir.
This is another interesting case. This is a 42-year-old female. History of walking difficulty in the form of slowness in walking as well as heaviness of both the legs for the last 2 years. Tendency to go backwards while standing. That is another complaint she was studying. No sensory or bladder problems. So history of walking difficulty in the form of slowness and heaviness of both the legs for the last 2 years. Look at the patient. I have examined in detail. There's no glabellar tab. Ocular movements were normal. Lower tails are all normal. Relax here. The tone upper lips were normal. There is no wasting. Operator side was negative. Power was normal. Both possible disturbances are normal. There is no kinesia of the finger movement. Finger nose incoordination. The upper limbs are quite normal. But lying down, there is appear to be spasticity more on one side. Power was 8% normal. Knee extension also normal. Dorsiflexion normal bilateral.
അങ്ങനെ ഇനി ഇരിക്കണം. ഞാൻ തള്ളാൻ സമ്മതിക്കരുത്. ഇത് പൊക്കി പിടിച്ചോ, പൊക്കി പിടിക്കേ.
Good hypertrophy of the ED.
ഈ ബലത്തിൽ ഇത് പിടിക്കണം.
EHL is also normal.
അത് തന്നെ. ഇനി ചവിട്ടിക്ക്. കയ്യിലോട്ട് ചവിട്ട്, എൻ്റെ കയ്യിലോട്ട് ചവിട്ട്.
Normal plantar flexion.
ഇത് നെറുക്കി പിടിച്ചേ, നല്ലപോലെ ഇറുക്കി പിടിച്ചേ. ഇത് ഇറുക്കി പിടിച്ചേ, എന്നിട്ട് ഇറുക്കി പിടിച്ചേ. മതി. ഇനി വെളിയിലോട്ട്
All muscles span, eversion muscle.
ഇങ്ങനെ ഇരിക്കണം. അതുപോലെ ഇതും പിടിച്ചേ.
Keep abduction muscle.
കീപ്പോട്ട് തള്ളിക്ക്.
Keep extension normal.
കീഴോട്ട് ഇതും തള്ളിക്ക്. മതി.
The reflexes, upper limbs normally elicited. Down reflex just elicitable. Both knee and knee jacks, both knee jacks are brisk, slightly more brisk on the right hand. Sorry, left more than the right. Bilaterally brisk. And knee jacks are both absent, even after reinforcement. Plantar, mute, indefinite. In fact, it found some other things, but some contraction that tend to Achilles. There is no contraction of the hamstring. Sensation touch normal.
2, 3, 4, 5, 6,
That is normal. Even in the S1 dermatom is also normal. Pain is normal, distally and proximally. Even vibration is also normal. He said yes. Non-position is normal. There is no heel shin in body.
Very good. അതേമാതിരി കാല് കൊണ്ട് ചെയ്തേ. ഒന്നുകൂടെ ചെയ്ത്.
Now let's say stance. The rhombogism is mildly positive. You don't know if it's called positive or not. With eyes open now, with eyes closed. Mild tendency to say forward. can call it positive. Yeah. She could stand on heel, but cannot lift up the first knee, probably because it's fracture. Mother can also stand on toes. She could get up from the chair without support. Renal blood test was negative. Random walking, not okay. Could do it without much problem. Now look at the gait of the patient now. It's got spasticity more on the left side. Okay, so summarizing finding, tailness normal, motor, tone power normal in the upper limb, lower limb, contracture of the mild contracture enteroachilles, spasticity of both the lower limb, power normal, detail normal in the upper limbs, knee jerk, disc bilateral, angle jerks are absent. Plantar indefinite, sensory system all normal. Rhombus mildly positive, gait mildly spastic, little more on the left side. Now here is the patient. So where is the localization? What is likely etiology?
Cervical cord with the involvement of bilateral, pyramidal as well as posterior column. And probably there is a associated peripheral nerve also.
Okay, why posterior column you said?
Because she has rhombus is positive, rhombus is positive.
Rhombus is mildly positive, but there is no sensory loss like posterior column vibration were all normal.
It's true, but she has she has symptomatically she tends to fall backwards.
Yeah,
and,
correct. Yeah, that's correct. Tend to fall backward. Okay, so then one point. Okay, remind me about the explanation later on, but there's a point. Okay, great. So we think they may be even the sensations are normal, maybe some other fibers may be affected. That's your explanation. Okay. Yes. So you think what likely etiology you like to keep in mind?
Like B12 deficiency, subacute combined degeneration.
Good. That's the thing. We never get pyramidal with absent angle. That is one of the things you have to keep in mind. Okay. Any other possibility? Anyone else?
Family history is there, sir.
No family history.
No nystagmus.
Pardon?
No nystagmus.
No nystagmus.
Sir, vision is normal?
Vision is normal. In fact, she was receiving syndopa from the peripheral hospital thing because they were tendency to fall backward with time. But she said there's no absolutely improvement with syndopa for 2 years.
Spinal cord, sir.
Pardon?
Lower thoracic spinal cord, sir. Lower thoracic upper lumbar spinal cord.
Maybe there may be lesions. The upper limbs are normal. It could be lesions lower thoracic cord, agreed. But then that alone cannot explain. No, angle jerks are also absent.
Could we consider degenerative attacks as a Friedreich's late onset?
Friedreich's late, that's a good possibility. But there's no ataxia per se. Yes, no cerebellar sign. He'll know lesion ataxia. Only thing was mild positive rhombogism, but no sensory loss anyway. Anyway, sometimes if a nerve conduction may show that, we'll do the nerve conduction and find out if sensory is affected.
Could it be any hereditary myeloneuropathy, sir?
Like
again, contracture, there is contracture. It could be a very long-standing issue. And is there some clawing in the toes, sir?
Okay. May I know your name? Doctor? Last time also I forgot your name. Can you tell me your name? Eh?
I'm Dr.
Oh,
Asha, sir. I'm one of your old students.
Yeah, Asha?
Yes, sir.
Okay, Asha. Okay. Okay, Asha. So that's a possibility.
Sir, distal myopathy, sir.
No, you don't say. How can you get distal myopathy with spasticity and disc reflexes? Okay, now let's see. These are the possibility: myeloradiculopathy, myeloneuropathy. So patient came with these investigations done from outside. MRI normal, brain normal. This spinal cord MRI done from outside. Again, normal. So what else you want? Nerve conduction. Okay. This is a nerve conduction from outside. Motor conduction normal except for the decreased CMAP amplitude from the right tibial. 2.63. Left tibial is normal. This is ulnar CMAP normal. This is sensory normal. This is the sural right, left, ulnar normal, median normal. This FA latency all normal.
What about H reflex?
Pardon?
H reflex.
Perfect. That is the thing I also wanted to do. Because suppose when the peripheral conduction is normal, we have to explain the absent angle check. There must be some reason for that. So if it is peripheral conduction normal, you have to think of lesion proximal to that, proximal to the ganglion. Just like last time we found a ganglion neuronopathy, I mean, a CISP patient, you have to do H reflex. So I'll show that later on because it is, so in fact, I wanted to first think of, so two things you have to sort out here. We have to find out the cause for the pyramidal lesion, cause for his absent angle check. So I thought I will do the MRI once again meticulously. So I did the MRI, cervical spine, thoracic spine, everything I did, and thin cuts I took. Sorry. Normal. This is a cervical spine, normal. Lumbar spine, whole spine again normal. Then I took the axial cut. This is again sagittal once again to find out any hyperdensity within the cord. Cervical not there, thoracic is not there. But there is some suspicious hyperdensity shown by the radiologist, but I am not very, we are not very, so one radiologist said it's not okay, it could be not be, we can't call it abnormal. One radiologist thought it may be abnormal. You can find out some hyperdensity there, no? The cord, within the cord. But it's not in the posterior cord. Maybe in the pyramidal tract, we don't know. That.
Yes, correct.
I thought it was there, but in other senior radiologists said it was quite normal.
What about MRI brain?
MRI also there. MRI brain previously done outside was normal, which I shown earlier. This is the, again I took the thin cut for the thoracic cord, find out any lesion, nothing lesion.
MRI brain was normal. Huh?
Normal. That I shown earlier. I did not repeat it because already it was done. So this is again the other cut to bring it down. The sagittal and axial together. We want to know whether there is any lesion there. Again, no. This is another again same picture. Some other sequence saying, so, yeah, whatever is spinal cord is normal. So we think more likely some kind of a non-compressive myelopathy or some thought. But again, we have to explain the angle check. So since the motor conduction is normal, but CMAP permittivity less on one side, but not on the other side. The question now is, was it an unrelated problem or related one? So is it a radiculopathy or a neuropathy? That anyway reflex has to be explained. So NCS shows a unlikely to be a peripheral nerve lesion because the peripheral conduction is normal. So however, we cannot rule out a radiculopathy or a demyelinating proximal nerve lesion on the plexus. We cannot rule out with peripheral nerve conduction. So what we did for the ask them to screen the plexus. There was some suspicious mild thickening of the L5S1 group. Again, they said not very convincing. So he found an IVDP at L5S1 level here. So the radiologists want a CT scan to find out, delineate it further, whether it's a canal stenosis. And they found a foraminal osteophytes L5S1 level. Here, you can make out the osteophytes there. This is, I will show the picture again. This is the right side. That's a canal stenosis. But it's not there on the left side. So radiologist telling that angle jack could have been due to foraminal stenosis. But I said it is present only on right side. It is only the right side. Patient bilateral absent angle jack. How can you explain that? So that again, this MRI radiological picture also cannot answer my question. So I was in the soup what to do next. So again, repeat and NCS was done. Again, the same finding I got before. Right tibial was little of low amplitude, but not severely affected. But otherwise, rest of the parameters normal. Sensory normal, F5 normal. So could suggest radiculopathy because of this finding. So what are the tests as Joy was telling? We did H reflex. H reflex is also normal. Latency and amplitude normal.
Sir, can the long-standing spasticity per se cause the contraction?
It could cause. Plantar flexor contraction cause contractions.
And because of the plantar flexor contraction, can the ankle reflex cannot be elicited?
Yeah, that cannot be explained. Angle jack loss cannot occur with just by a contracture alone. It's not that much severe contracture to remaining rigid like that. It's only mild contracture.
So in this case, the CMAP amplitude should be normal, no? If there is a, because there is abnormality of the tibial CMAP motor condition also. That means there is definitely some action.
Yeah.
The tibial CMAP is reduced. That means there should be some axonal dropout should be there, right?
Correct. Perfectly right. On one side it is there.
Yeah.
Maybe other side also may be there. You're right.
That is on the right side, no?
That's on the right side, but that cannot explain the absent angle check.
EMG
EMG was
CSF study.
Okay. So B12 serum was done, already done from outside. That is, I did not repeat it. So ultrasound abdomen was done, normal, and ANA profile was done, which is normal. And CSF was done. CSF was protein 18, glucose 84, total count, cell count 1. Even though your CSF is there, what do you want now?
So spasticity is confirmed, sir.
Pardon?
Spasticity, sir. Can we say spasticity is really present?
Yeah, it is present. That is a complaint. Complaint was is dragging the foot. And also on examination, at least right side, you can say it's not there. Left side is definitely there. You want to see the gait once again, I can show.
No, because of the ankle contracture, sometimes the gait can be misleading.
Yeah. Correct. But she has got weak. When you have examined also, there is a spasticity of the cortices. And the reflexes were brisk.
Any family history?
No family history. No.
What about homocysteine and VDR?
The CSF VDR done. CSF VDR.
Sir, methylmalonic acid and homocysteine, everything is normal, sir.
Homocysteine is normal. Methylmalonic acid is not done here, as you know.
Can it be an HSP variant?
Could be HSP variant. So what else will you consider now? What do you want to know?
MRI brain to look for the ear of link signs.
MRI brain already done normal.
Examine the family members and see.
No family. No family members are not affected.
VDR is negative. CS.
VDR was not done.
Copper levels, copper.
The copper was not done because it's not, you see, it's not something like a subacute combination. It's not there, either MRI wise, electrophysiologically, and copper can be done, but it's not, clinical findings are not fitting.
Trial of B12, sir.
No. I send the send for clinical exome sequencing.
Sir, one more thing. Sir, can you get this? Sir, can you get the same finding with a tethered cord?
Yes, you can get a that code, but there will be some sensory findings also in that thing. And even MRI finding will be abnormal. The spine lumbar MRI is normal. There is no tethered cord or not the container. Clinically, it can be agreed with you, but not in this patient because the MRI is normal. Okay. Spasticity can occur. Spasticity can occur tethered cord because the roots get different to the dura. So stretching can produce cord involvement.
Spasticity known for HSP variant.
Now this is what you find exome sequencing. You got a spastic paraplegia 10. This is the finding. Now going back, something that about HSP 10. This can occur with the Pescavus and polyneuropathy. And this is a large study of this KIFY variant mutations. And you can see this the presentation is hyperreflexia, except angle jets and spastic gait. Clinical picture presentation fits in with that. This is the KIFY, that is kinesin heavy chain mutation. No, my question is not that. What is the clue in this patient to suspect HSP?
Non-compressive myelopathy.
Ankle contractures.
Contractures.
Now look at the feet. In fact, Asha picked up that finding. He has got a Pescavus. See, now I'll show the picture once again. See the fingers here. There's a contracture, and he has got a Pescavus on the foot, not on the right. Did you see that? That was the finding. In fact, I did not notice, frankly telling, I did not diagnose this HSP in the beginning. So I was thinking for the 3-4 days, I was thinking about what could be this. That is why I did all that when a CT scan of the spine and my H reflex, CSF, everything I did. Then again, I couldn't get an answer. Then again, I was just thinking whether could be hereditary. But before I asked the patient for a clinical exome sequencing, which cost 13,000 rupees, I should be definite. I should not waste their money. I had this in mind long time to do the sequencing. But when I find this thing, I thought we will do that because of the Pescavus which is present. So that is the clue to send the patient and send the blood for clinical exome sequencing.
What does Pescavus suggest? That was long-standing or something?
It's long-standing in the weakness and wasting small muscles of the foot. Because the arch which is maintained by the small muscles is abnormal, so become a Pescavus.
But asymmetry is not.
Yeah, then usually symmetry is the one, but here is asymmetrical. But still that is there. Angle jack is symmetrical.
But she had symptoms only for 5 years, no?
2 years.
2 years. So you mean to say that she had symptoms even when she had this problem even prior to that?
This foot abnormality might have been there earlier.
Sir, any lesions or any abnormality in the MR is available?
No, in fact, getting the
brain.
Yeah, after getting this thing, what do you call the genetic testing, I went back and checked the MRI itself, the previous MRI, nothing there. The MRI, I can show you the brain. But MRI may not show all the time, only in SPG is 17, 10 something, it's not 10, 17 or some other thing you find ear of link sign or thin corpusculosum. So it's just been there are high, so many variants are there. Cerebellar, peripheral neuropathy, optic atrophy, ophthalmoplegia, laryngeal involvement, everything is there. So,
sir, recently I had a patient from Gulf, some difficulty in walking. His MR showed that classical, you taught last time, ear of link sign.
yeah.
So,
if you find that there's, of course, for a thin corpusculosum, okay, you are happy. But here, nothing was there in the MRI. No quad atrophy, no hyperintensity in the cord testing CD.
Sir, one doubt may I ask. Suppose in a case, if we are noticing this sort of foot deformity incidentally, the patient does not have spasticity, the patient is not falling. For example, if you are having a patient who is coming to you with a diabetic neuropathic pain, and when you examine, you find that this patient is having this sort of intrinsic foot muscle weakness where there is clawing.
Yeah.
What would we think of as the etiology, sir? Because if it is a peripheral neuropathy,
it's a part of peripheral neuropathy only. A person, suppose you've got some other explanation to some other reason to explain the small muscle wasting and weakness, of course it is due to that only.
That only.
Yeah. Any long-standing neuropathy can definitely produce.
Sir, the reason for the doubt being, when we say of a peripheral neuropathy and we think about a length-dependent neuropathy, wouldn't we think that the patient would be having difficulty in dorsiflexing the toe, dorsiflexing the ankle before the patient develops plantar flexion deformity? I don't know.
No, because this is basically due to the weakness of the small muscles of the foot. So that's not going to cause much of a problem to the patient. So many people are walking about club foot without any symptoms.
Okay, sir.
Because it's not going much of a disability. The maximum disability can occur when the adductor hallucis is weak. They may not be able to grip the chappals, what do you call that thing which holds the
grip.
Whatever it is. I don't know English word for that. So that will be a problem. Otherwise, usually they don't have any problem.
Okay, sir.
Club foot per se is not going to cause any problem.
Sir, in peripheral neuropathy, is it possible that to have the EDB affected first, followed by the intrinsic foot muscles?
No. That is the one important, as Umar pointed out correctly. So this is one important point to differentiate a distal myopathy from a neuropathic or antecondylar problem. In neuropathic problem, always the intrinsic muscle foot is affected first. That is why you get in CMD, Charcot-Marie Tooth disease and HSMN and all, you get the so-called hammer toes, so-called clubfoot deformity, etc. But in distal myopathy, it will not affect the distal small muscles of the foot. That is why they get sparing of the EDB, sparing of the small muscles of the foot. They don't get clubfoot. But the dorsiflexus will be weak, plantar flexus is weak. For example, if you take the classical GNE myopathy, the dorsiflexus are affected first. They can have wasting of the EDB also rarely, but classically in muscular dystrophies, the EDB is hypertrophied or preserved. So similarly in the hand also, if you get patient coming with small muscle wasting in the hand, don't think of myopathy. It is more likely to be a neuropathic process. For example, body myositis, they have the finger flexion weak muscles and finger extension weakness, not the small muscles of the hand. So that's a very important clue because neuropathy is a length-dependent one. So they are going to affect the small muscles first before you get the affection of the tibial muscles or the plantar flexor muscles. So that's one important point to differentiate myopathy from antecondylar neuropathic process.
Sir, what is the localization here for the angle jerk, absent angle jerk?
Yeah, now that will be very difficult to explain. Now you can say that it may be some kind of a neuropathic process which is affected. Now, many of these hereditary conditions, which are the fibers affected, we don't know. It may be so selectively affecting the reflex carrying fibers. So degenerative disease or metabolic disease got peculiarity in that they are so selective. That is why you get, for example, motor neuron, it only affects pyramidal tract till the end. No other tracts are affected. Similarly, in certain hereditary neuropathy, some of them affect only the small. That is hereditary the small fiber neuropathy, presenting only with autonomic involvement. Some present only with motor involvement, some only with large fiber involvement. So some selectivity is there. So in HSP variant, why it is angiogenic is obviously it is a peripheral process. It is not due to the motor fiber involvement, because in motor fiber involvement causes such angiogenic loss. It has to be the reflex carrying fibers of the muscle spindle is affected, maybe in the peripheral nerve itself, but it has selectively picked up that fibers, sparing the sensory fibers, sparing the other motor fibers. That's the only way to explain that.
Sir, the clubfoot is there, this hammer toes are there.
Yeah.
So small muscles are weak when you examined?
No, it is not weak. It is not weak. Because
then how will you explain?
Yeah, it only means that some of the muscles are called the contracture and body is a deformity. The power loss may not be that severe. If it is severe only, it produces weakness. And small muscle weakness, which small we can explain, we can get examined. Only the adductor hallucis. All other things we are going to be at fault. How often we have done introversion of the toes? We do not know the normal power of the introversion of the toes. And if you ask the patient to activate the introversion, normally people cannot do how to activate the introversion. Even we cannot do. Because we are not using that muscle for our activities.
And how will you explain the asymmetry, sir?
Even in degenerative disease, some asymmetry is not uncommon. You can have that.
Sir, in this case, there is a postural instability. She tends to fall backwards.
Yeah,
mild rhombolysis.
Yeah, that is most likely because of the contracture. Maybe due to the contracture of the tendon Achilles. That is why she's got a tendency to keep the trunk backward to maintain the central gap. That is only explanation. There's no real postural imbalance. Seeing that only the doctors who have seen the patient previously must put the patient on syndrome.
Or the rectus spinae muscles may be spastic. That can also explain.
Yeah, but that may be.
What can we give, sir?
Sir, one doubt.
Yeah, please. Yeah.
Sir, the reflex carrying, is it? I mean, I thought it is the same as that which carries the large thickly myelinated fibers which carry the joint position sense and.
No. I'll tell you that. Bindu, I'll clarify that point. See, the reflex carrying fibers are the largest 1A fibers, which are different from the fibers which carry the proprioceptive input. They are also large fibers, but the fastest is the 1A fibers from the muscle spindle. They're entirely different. They are entirely different from that carrying those fibers carrying the proprioceptive loss. Okay. The classical example is Miller-Fisher syndrome. In Miller-Fisher syndrome, you can get normal sensation, normal sensory conduction. The joint position will be normal. Still, the patient's got reflexion ataxia because the input from the muscle spindle is affected. Those coming from the muscle spindle is affected. So the fibers are different.
Yes, sir.
What can we give, sir, for symptomatic?
In fact, even before the clinical exam sequence came, I put the patient on Leorosal, and I asked her to come after 1 month for getting, after the result has come. She has not come back yet. She may be coming back and in another 1 week's time since the result has come. And put her increasing doses of Leorosal. Some people get some mild benefit. I don't know how far it will be working.
Sir, if they're affording, we can give baclofen pump, sir. Sometimes the lower limb alone is affected.
She's not so symptomatic for that.
Yeah, that's the thing. She's not that symptomatic. And baclofen can be a very severe spasticity, but I have seen one patient who had received baclofen pump. So he had a lot of problems subsequently. Sometimes the pump will fail, very costly. Very costly. And he had a lot of
Following up the patient is difficult. They'll be having a lot of complications.
They can develop it. In our setup, it is very, very difficult and exorbitantly costly.
Sir, in this context of HSP, that the dorsal cord hyperintensity is significant, no, sir?
It may be significant. But that's what initially we thought there's no dorsal cord. That was actually not in the posterior.
Sorry, dorsal, ventral. Pyramidal.
Yeah, correct. The pyramidal range. Exactly. That may be significant. That may be significant.
Sir, hammer tome, clawing of tome, same alle?
They're essentially the same. Essentially the same. Both will have extension of the only difference between that, I'll tell you a little more detail. In hammer toe, E by means that there is hyperextension of the metacarpal joint and flexion of the interphalangeal joint only, first one. Whereas in clawing, both the two, the middle and distal phalanx, both have got flexed position. Here, just only the first one, the extension of the metacarpal one, the other whole thing will be flexed. That is hammer toe. There won't be, the other toes will not show any flexion of the distal phalanx. But essentially, they are all same. Not much of a difference. Okay. Any other questions?
So is this a sporadic mutational? Because there is no family history.
No family history. No family history. No, this is the one thing. So that the only thing is when you examine, look carefully for the certain signs, which they may. So in fact, initially I did not pick up this finding at all. Only subsequently when we know everything, every way is how it's blocked, I could not get through what the diagnosis I was getting, looking for this finding. Okay. So shall we close for today? This is from the literature from HSP10 showing the hammer toes and contraction. If you look back, that's the same thing similar to our patient.
Sir, can I ask one doubt?
Yeah, please.
In Miller-Fisher syndrome, rhombus sign will be positive.
It can be positive. Rhombus sign can be positive because it's an ataxia is there, no? That will be worse than with cyclos also. But classically, it may or may not be positive. They can have classical cerebellar sign, cerebellar ataxia, not the sensory ataxia.
Spinocerebellar fibers are affected there?
Correct. Exactly. I tell you, there are these fibers from the joint, from the muscle spindle. They, in fact, go to two pathways. One through the posterior column, they go to your parietal cortex, and part of it, a large chunk, goes to the cerebellum. The other part goes to the spinocerebellar pathway, go to the class column. From there, go to the spinocerebellar pathway to the cerebellum. So this proprioceptive input main role is to maintain the maintain the coordination and balance. So that is why in Friedreich's ataxia, you get a typical cerebellar ataxia due to the effect on the spinal cord, affecting the spinocerebellar tract. In Friedreich's, the cerebellum get affected only much later. The ataxia is due to the cord involved. The cord gets atrophied. So they get a cerebellar type of ataxia. Yeah.
Miller-Fisher, which is the tract involved?
Which is the?
Spinal tract involved in Miller-Fisher.
Miller-Fisher is a peripheral problem. Miller-Fisher, it is the peripheral nerves are affected. Where the fibers coming from the joint, the muscle spindles are affected. The proprioceptive input, that's again, muscle spindles also maintaining the proprioceptive input. That is affected. That's why they get the imbalance.
So where is the localization of the absent ankle reflex in these patients?
That's what I was explaining initially. It's only way to explain is that those fibers, reflex carrying fibers, which arise from the muscle spindles, are affected in the peripheral nerves. It's a part of the peripheral neuropathy, but only thing is that those fibers are selectively affected, sparing the fibers carrying the sensation, sparing the fibers mediating the motor function. By that alone is something that's why the hereditary diseases behave or neurometabolic disease behave. Selectivity. James in about selectivity with selectivity. Yes. Rose?
In diabetic neuropathy, many often we get the absent CMAP and but the patient is having normal motor power. What is the explanation?
No, the absent CMAP and normal motor power. See, if you get a muscle, if the CMAP is totally absent, that muscle will be invariably weak. Okay. So suppose you can absent CMAP from EDB. We are picking from the EDB. Okay. That if it is CMAP, if it is 0, patient has normal power. Because EDB has no useful function, motor function at all. Only problem, mild extension. In such a situation, what you do when CMAP is absent from, say, for EDB conferral nerve, always do a proximal pickup. That is pickup from the peroneal, in the case of tibial, pickup from the gastrocnemius. If that is also grossly decreased, that patient cannot have a normal power. Now remember that more than 50% of the muscle fibers should be lost to produce clinically significant weakness. So you can have a decrease in the CMAP amplitude of more than 50% with grade 5 power. That also remember that. So the CMAP, if it is absent in a clinically significantly weak muscle, so for example, if your hamstring is absent or your tibialis anterior is weak, the CMAP is absent, that should be weak.
Thank you.
But we are doing it from the EDB, no? Or AHL, abductor hallucis. They are very small muscles, the weakness of which will not produce any significant disability.
So for TA also, for tibial nerve also, same applicable.
Yeah, TA also. That's why we do the proximal pickup always, invariably. In peripheral neuropathy being an axonopathy, dying back phenomena, only the small muscles be affected first. When in doubt, you have to do a proximal. Then only you can differentiate whether it's a mononeuropathy or the conferral proximally affected.
So for tibial, you have to tibial pickup, gastro pickup.
Yeah, gastro pickup. Suppose you get an absent CMAP from tibial, EDB, and a good CMAP from TA. That means it's an axon of dying back phenomenon. It's not a neuropathy or the conferral nerve occurring at this pupillar head.
Okay.
Okay. Shall we close it?
Yes. Okay.
Okay. Good night. Thank you.